Yeah. Well, first, I always want to start off talking to the parent, and I want to find out exactly why they came through my front door. Because people come to a private practice for a whole variety of reasons. It's not so restricted to they have to do better in school. I mean, it can be any number of issues. So I just always start off talking to the parent first, finding out what's really driving them to come and see me, and that's how we get started. Maybe the doctor's script. In New York State, you don't need a script to do an evaluation, but you do need a script to do therapy. We usually encourage families to get a script anyway because we like when the pediatricians are involved. Because a lot of times, if we're going to be recommending therapy or referring them or asking for something else, we want the doctor to be in the loop like from the first step because we're going to require their referral for that stuff anyway. So, from my perspective, it's better for families to coordinate these efforts with the pediatricians. Um, and actually, I think the pediatricians appreciate that because, it's just more of a team orientation, and collaboration so that their patients are getting good care. I think that one of the biggest differences in the assessment, it's not just with assessment tools, but it's with assessment process in total. So, as an example, we take a really detailed developmental and medical history. You guys have seen that form, because that's the form that we used in the beginning of the year to do the developmental history. A lot of times in school systems, it's just administration of standardized assessments, and the developmental history would be kind of cursory, um, and not be quite so in depth. So, so I think from a process standpoint, we're much more likely to spend a whole lot of time on those kinds of issues. And also, we have access to the family. A lot of times, therapists in schools don't have access to the family, so they're not able to ask them those kinds of questions and get that kind of information from them as easily as we are because they're sitting right there in in the office with us. Um, what was your question?
Is there a certain type of assessment?
Oh, other types of assessments. Right. Okay, right. So I still want to finish talking about assessment process. The other thing that we do a lot more of, I think, is a lot more clinical observation and clinical interpretation. So rather than just doing the standardized tests, so not just doing the P-body, but actually assessing range of motion, tone, strength, reflexes, posture, movement skill from more of a qualitative basis, I think it's much more in depth. So in general, there's a lot of non-standardized clinical assessment that goes on too. That's probably a little bit more in depth than what happens in school most of the time. That's not to say that schools can't do that, but I think that in general it happens a little bit less.
Okay.
Time out. Sorry, I have another answer for that. Another thing, another thing that I do a lot of too is sometimes when I do use COTAs in assessment process, it's toward the end to do qualitative play-based assessment with the child. Um, and I do that a lot because sometimes I like to have conversations with the parents at the end of the assessment, and I don't need or want the child to be in earshot of everything that we're talking about. So I'll pass them off to the COTA, and I'll just ask the COTA to do some activities with the child, and then almost like a treatment session kind of a thing, and then I can get some feedback and observations from the COTA about how they're doing on functional play-based tests that I might not actually do with the child in an assessment context. So sometimes I'll do that.
Okay, so we talk a lot about like being in different settings or being in different areas for assessments, depending on which ones like your site compares more. owning the clinic, do you kind of give guidelines to your therapist or kind of push them in a certain way towards assessments that you prefer to see as opposed to something that might be not?
Yeah, it's kind of easy to control because, like, I buy the assessments. So if I don't have it available in the clinic, it's not likely that it's going to be done. So that's kind of how I control things, you know. That's not to say that we don't have some assessments in the clinic that we use less. But yeah, usually as part of the orientation process for new therapists, kind of talk a little bit about which assessments are preferable and which ones are less preferable. Yeah, so we do that.
So which other, is there assessments that you kind of do use more than others and one that you sort of only use in special cases?
Yeah. And again, a lot of it's going to depend on the age of the child. Okay, so for infants, a lot of times, infants and toddlers, we'll use the Peabody or the Alberta Infant Motor Scale. Or we'll do the infant toddler sensory profile. So those are really typical things that we might do with really young kids. For preschoolers, it would be really common for us to use the Peabody. It would be much less common to do the Miller function participation scales, but we've been known to do that on occasion. For school-age kids, kind of the standards that I roll through would be the VMI, the MVPT, the Jordan, the fine motor portion of the wide range assessment of visual motor abilities. That's a nice pegboard test. Clinical observations of, based on Earhart or those kinds of things. Pretty much all the assessments that you've seen in this class, you've seen them because they're most common and they're the best assessments, and they're the ones that I tend to use. I used to do the SIFT a lot more. I very rarely do that now. I think we talked about that when we talked about the SIFT. We do the sensory profile. When you have more social and self-esteem issues, less commonly, I don't give it to every child, but stuff like the COSA, the Children's Occupational Self-Appraisal, or the Piers-Harris. I think we talked about that too. The Children's Self-Concept Scale. Did we talk about that one? That one too? Yeah. I may have mentioned it, the Piers-Harris. It's just a self-concept scale. Kind of the most one. Or the Cape Pack. Well, I should have mentioned the Hawaii earlier on for 0 to 6. We use the Hawaii, and but that's more when we're doing just the naturalistic observation type of assessment. So those are all the common ones. Less commonly, the test of handwriting skills is an assessment that we use, especially for older kids, when we're trying to document their legibility and speed, especially if they're looking for accommodations, like their college, whatever college, SATs or whatever else they might be taking. So we'll use that sometimes too.
So after you do the assessment for a child and you have other self-assessment hands, what do you do with it? Do you have your own personal system, or do you have?
Yeah, my own system is, I always have my note sheet, of things that I'm jotting down and writing down during the assessment, where I have an ongoing tabulation of all the important information that I want to put into the evaluation. And I have an evaluation format that I use, that's pretty standardized for me, that has general observations at the top, and then a physical assessment that includes motor and sensory issues, and a cognitive assessment, and then a social assessment. and then looking at occupational behavior, self-care, and pre-academic and play skills, and how all these things that came before are impacting in functional areas, and then a summary. So I kind of take all that information and I plug it into my personally standardized format that I like to use. And that's how I write my reports.
So do those reports go with billing? What happens with it? Or it's just like put in a file and when it comes in, go out and look at it again?
No, well, the reports, have to be reviewed with the parents. Most of the time, as much as possible, I like to sit with the parent after I've actually done it and give them some immediate feedback. Most of the time, I'm able to do that, so I'm able to tell them exactly, how the child did, what the recommendations are. Sometimes you might not have time to score it sort of on the fly. And so it's kind of interesting. Like when I was watching you guys do your practicals, like you guys are just learning it, so it took you the full 20 minutes to answer those questions. When you become very, very experienced, it'll probably take you like 2 minutes to do that. 2 minutes only, to be able to look at those results up in the book, process them, understand what they are, and then be able to come back and give recommendations. So that's something that I try to do, is give the parents feedback immediately.